Hey everybody, it's Adam again, and we're here to have another exciting epidemiology and biostats lecture. And today we're going to be talking about assessment of risk and benefit in epidemiologic studies. Here are the objectives, and we'll go over these in more detail as we get through the lecture. All right. So when looking at causal research in epidemiology, we're looking for, again, not just a correlation or some sort of association. We're looking for actual causal relationship here. It's important that, again, we be able to define things like our variables, like which ones are independent versus dependent. And so looking at the independent variable, this is usually going to be a distinction between people who have had an exposure to a risk or in potentially a protective factor, and those who have had no exposure to it, right? So they either you've had exposure or you haven't. That's usually the independent variable they're going to look at. Think about risk being like, say, exposure to lead. Think about protective factors being something like, exposure to, safe sex practices class or something like that in high school, right? Some of those things could be protective factors. A lot of times you're looking at risk factors as well. And then you're going to have the dependent variable is typically going to be a distinction between people who have the disease or the outcome that you're looking at versus those who do not. So for instance, with lead exposure, you're looking for things like an outcome like lowered IQ or lower, say, high school graduation rates, things like that. And that's a dependent variable because it's based on the independent variable, whether or not they've had exposure to that factor that we're looking at. Of course, when you're looking at these measurements, there's always going to be random errors, there's going to be biases, there's going to be confounders, and so we need to take that into account when we're looking at these studies and making sure that the conclusions the authors are coming to are supported by the data that we're looking at. But you'll find in many studies that you're not just looking at one independent variable. Sometimes you can be looking at several variables, several things that could be possibly causal, right? Because we know that things like disease occurrence is usually pretty complicated for the most part. So for instance, when you can look at multiple things at the same time, looking at the outcome of hypertension, that'll be our dependent variable, relating it back to age and gender. So you can see things like, before the age of 50, guys are typically more likely to become hypertensive, but then after 50, you're going to see that women are more likely to become hypertensive. So based on that, you can see that both age and gender can have an effect on here. And again, those would be considered independent variables, the outcome being hypertension. Not only that, but you can find that you have to measure some of these different independent variables based on the strength of the exposure to a risk factor, right? So how high of an exposure have they had? How strong of an exposure? How long have they been exposed to that can also be a factor as well. Or sometimes you're looking at a combination of the both, right? Or both of these factors here. So a good example of this would be like cigarette smoking. Typically, you're going to see it being expressed as terms of pack years. This is going to be both an average of the duration that someone was smoking for, along with the amount that they were smoking to get an idea for how strong of an exposure they had and for how long. So for instance, you can have pack years being expressed as the average number of packs smoked per day times the number of years of smoking. So for instance, if you had someone who had a 20 pack year exposure, it could be that they were just smoking 1 pack a day on average for 20 years, or they could be smoking 2 packs a day on average for 10 years. So basically by saying that, by showing that, you can see that their exposure is roughly equivalent, even though someone was just smoking much more intensely for a shorter period of time. A lot of times when you're looking at risk factors, it can be really hard to determine kind of this time of onset of exposure. It's not oftentimes that people say, yep, January 1, I'm going to start my sedentary lifestyle. I'm going to start to, eat a whole bunch of extra sodium. It's usually going to be kind of on this continuum. It's difficult to really determine when some of these risk factors have actually started. The other thing you have to consider as well is this looking at the different disease severity and the fact that, you can have people who have relatively mild hypertension, which probably isn't going to be as dangerous as really severe malignant hypertension. But when you look at a lot of these studies, typically you're going to find that exposures and outcomes are just going to be expressed as kind of a binary, either present or absent. And so you kind of lose a lot of that granularity there. You lose a lot of the details in order to lump people into these different categories. And so, again, when you are looking at these studies, typically, again, we're kind of lumping everyone into these groups where they either exposed or unexposed, and they either have the disease or not. You normally will see these kind of 2x2 sort of tables. Obviously, as you introduce more outcome variables or more independent variables, that this can get more get larger, but a lot of times it will just be expressed as this kind of 2 by 2 sort of table. So we've seen tables like this previously, especially if you think back to our chi-square analyses where they were looking at the, say, certain outcome or certain exposure to see if that was happening between different groups based on just random chance alone, or whether it was due to an actually statistically significant difference between the groups. And so just to kind of walk you again through it very briefly, we can see that A, in this case, again, looking at your table, you should see a risk factor here as being either positive, negative, and there's a totals column or row. And then looking at disease status, either present or absent. So again, the risk factor is going to be our independent variable here versus the disease status would be our dependent variable, and then again, totals column here. So basically, A, in this case, would be all subjects who have both the risk factor and the disease. B would be subjects who had the risk factor but they did not develop the disease. So maybe they are, if you're looking at smoking and lung cancer, they smoked, but they did not develop lung cancer. C in this case would be subjects who had the disease but not the risk factor. So again, people can develop lung cancer without actually having smoked ever. And then D would be people without the risk factor or the disease that happened there. Okay, so those are kind of the main categories that people can fall into based on both risk factors and disease. Then when you're looking at the totals, you can see this is important for some of our analyses where A plus B, or this kind of positive risk factor row here, is going to be all subjects with the risk factor. C plus D is going to be all of those people who did not have the risk factor. And then looking at the columns here, you can see that the disease present column is going to be A plus C, and then those who did not have the disease would be B plus D, and then finally A, B, C, and D together, all is going to be basically all the study subjects you had at the end of the day. So using this information, we're able to develop these sort of like kind of chi-square sort of analyses where we can actually determine whether or not this risk factor being present had a statistically significant effect on whether disease popped up or not, where there's any kind of association there. And just when thinking back about the different types of studies you can perform, remember that your causal research is going to be measuring the differences in these outcomes, but it can change based on what type of study you're doing. So for instance, with a cohort study, it's going to be where you're going to group people based on their exposure, whether or not they have a risk factor, and then you're looking usually forward to determine whether they have the disease or not. So again, you're going to be measuring that difference between the frequency of disease in those groups of people with or without the risk factor, right? On the other hand, when looking at a case control study, you're kind of starting at the end point where people already had the disease or not, and then you're looking backwards typically to see, the frequency of those people, whether or not they had this risk factor that was present, right? So again, keep that in mind, because again, that is going to be important when you're looking at your results to see like, okay, what are we looking at? Are we looking at the actual occurrence of disease, or are we looking at the kind of the prevalence of these risk factors being present in people who already had the disease or not? Now, how you define your study group can be basically anything you want. The exposure can be things like nutritional factors, so whether or not you had a high or low salt diet, exposure to aspartame in diet sodas. I say that as drinking one right now, so maybe I could be one of these studies one day. It could be environmental factors, so whether or not someone was exposed to radiation after a potential nuclear event, or say like the Chernobyl disaster in this case. Can be behavioral thing like cigarette smoking. Sometimes it could be a physiologic characteristics, maybe someone who just has a high total cholesterol in the blood, and has a high blood pressure, whatever happens to be. And then you can look at things like medical interventions or even public health interventions, whether or not someone had exposure to some sort of public health outreach, like some sort of class or something, or a vaccine. Again, these can all be your exposures. These are all going to be the independent variables that you're kind of assigning people into your groups to, if you're doing a kind of sort of cohort study, right? Now, if I was doing a case control study, this would actually be the dependent variable, where I would be looking initially at people who had the disease outcome that I was interested in, and then looking backwards to see whether or not they had this exposure in question. So depending on the study, you can have exposure either being a dependent or an independent variable. So this is an important concept. When you're comparing these groups, it's important to understand when you're looking at risk or protection of a certain exposure, you need to understand whether you're going to be looking at absolute differences between the groups or just relative differences between the groups, and that can be defined based on the type of study you're doing. So for instance, when you're doing a case control study, you're only really able to, because again, you're typically looking backwards in those cases, you're only able to measure sort of relative measures of risk, right? So I can see what was the risk of this group having exposure to this risk factor or this protective factor versus this other group who did not have the disease. And so by doing that, you're dividing one by the other to get sort of a relative measure of risk. When you're doing more prospective sort of studies or these cohort studies, they're randomized based on the actual exposure itself. This is where you're going to be able to look at more. Not only can you look at relative measures of risk, but we'll also look at absolute differences in risk. So again, relative measures of risk is just going to be one group divided by the other group, right? And we'll look at examples of this in a second to make it more clear. Absolute would be when you're subtracting one group from the other. Okay, so an absolute difference between the two groups here. They provide different information, and we're going to go into that to see when those are useful and what those kind of tell us moving forward. Remember, it's also very important that we determine what our statistical level of significance is going to be. Again, usually 0.05, p-value of 0.05 or less is typically what we're going to consider to be, statistically significant. Always keep in mind, even if you do show a statistically significant difference, it needs to be clinically important as well, because otherwise it could be a real difference, but who cares, right? Because it's not really clinically relevant. The other thing to consider is that if the difference, appears to be clinically important, but we were not able to achieve statistical significance, it could be a false negative, right? It could be a type 2 sort of error where either we didn't have a big enough sample size to actually find this, and we would consider that study to be underpowered in those cases. So first off, we're going to look at absolute differences in risk. And so when you're measuring disease frequency, typically you're going to be looking at risk when you're doing these like sort of cohort studies, or if you're doing like a clinical trial where you'd actually randomize people to different groups to have exposure to one thing versus another. And then typically when you're looking at more population-based reporting systems, so imagine you're getting data from death statistics in the US or something like that, this is where you're going to be looking at rates. You'll see rates of disease and death data coming from these larger systems. You can kind of think about these, for at least our purposes, relatively interchangeably when discussing absolute differences in risk. And essentially what we're just going to be looking at in this case are either going to be expressed as a risk difference or a rate difference. Again, it's just going to be one minus the other. So for instance, the risk difference here, this is an absolute difference in risk, is we're going to be taking the risk in the exposed group minus the risk in the unexposed group, right? Or the risk of developing hypertension in one group who had a high salt diet minus the risk of developing hypertension in the low salt diet, for instance, right? Just subtracting one versus the other. So you can see basically the people had the exposure in question, their risk was this many % higher, an absolute difference in the numbers, than those who had a low salt diet, for instance. Rate differences are exactly the same. It's just you're using a rate developed from whatever your data set is versus risk. Just one minus the other. It's an absolute difference in risk. Now, if there were no differences between the groups, so say for instance that the type of salt intake a person had no effect on their development of hypertension, the risk difference should be 0, right? So the risk should be the same regardless of the exposure in those cases. So in those instances where the risk difference is 0, you could conclude that exposure has no difference on the risk of developing the disease, right? When you're looking at statistical tests to compare these, typically you're going to get a confidence interval that goes in that is going to accompany that risk the difference, the absolute risk difference. And again, if this is one of those things where if it encompasses 0, the confidence interval goes below 0 and above 0, that would also be considered non-significant. Okay, so keep that in mind as we move forward. Again, when we're looking at relative differences, so you're dividing one versus the other, one will be your level of significance to consider when you're looking at confidence intervals. So just kind of keep that in the back of your mind. Now, if you're looking at something like exposure that is harmful, so for instance, cigarette smoking, the risk difference would expect to be greater. If you're looking at lung cancer or development of COPD, you would expect that risk percentage to be higher because the risk of developing the disease in question would be higher in the group that was exposed than the one that was not exposed. When you subtract that out, that would be a positive number. On the other hand, if you're looking at a protective factor, so something like a vaccine, you would expect the risk of disease to be lower, so say development of flu or pertussis or something like that, you would expect that to be lower, and so that would be a negative number, right? So negative numbers when looking at absolute risk differences usually impart some sort of protective feature to it, okay? So another name for this risk difference is also going to be attributable risk, and so it's just going to be an estimate of the amount of risk that is going to be attributable to that particular risk factor, right? So the amount of risk that is attributable to cigarette smoking in the development of lung cancer. So you can kind of think about it like that. So you can go back and consult that table we were looking at previously, and I'm not going to have you figure out the exact math, and I'm not going to have you actually do these sort of calculations here, but if I were to give you two risks from two different groups, I would expect you to be able to do an absolute difference here, because again, it's just one minus the other. It's pretty easy math in those regards. But looking at how we get these calculations of risk in the exposed group versus the unexposed, you can go back and look at those variables we were talking about, where basically A was the number of people who had a risk factor and that developed the disease, and then B was going to be the people who had a risk factor or who were exposed but developed no disease. So again, this is your denominator. So these are all people who had the exposure, which will be your denominator. The numerator is the people who actually developed the disease in that group. On the other hand, C is going to be the people who developed disease who are not exposed to the risk factor. And then you have C plus D be your denominator. So these are all people who are non-exposed. I'm sorry, C is going to be the number of people who develop the disease. I'm sorry, I apologize if I said that incorrectly. But again, you can kind of see where the math is coming from here. You get these numbers here. They should be percentages, right? So the percentage of people who develop the disease out of that total there. And then you would just take these numbers and you would subtract the risk of the exposed group minus the risk of the unexposed group. And then what you're going to have be your product here is going to be this attributable risk. Okay. So again, if this is a something that imparts some danger or some sort of damaging factor here, you would expect this risk to be larger than those who are unexposed. So you'd imagine this would be a positive number. On the other hand, if this is a protective exposure, so something like a vaccine, you'd expect this number to be lower than this number here, the unexposed, and so this would be a negative number. This is attributable risk. And so again, negative numbers usually imply some sort of protective feature. Positive numbers usually are kind of signaling there's some sort of risk associated with that you're more likely to develop the disease in question. So again, going back to this table, when you're getting the risk for the group who had the risk factor, right? So you're looking at the people who are positive for the risk factor, you're doing A divided by all those people who had the risk factor, right? So A divided by A plus B, right? So that we get this percentage of people who had the risk factor and then developed the disease. And then for people without the risk factor, people who are unexposed, you're going to do C divided by C plus D. This will be your denominator. So again, that kind of makes sense. And then you subtract one versus the other, and then you get your attributable risk due to that risk factor. So here's an example where we can look at an actual real-world application of absolute differences in risk. This is where we're going to look at some data. This is back in 1986, and it was comparing lung cancer death rates between male patients and male smokers and non-smokers in the U.S. and in the U.K. Notice here that this is age-adjusted death rates. That means that we take out the effect of age, and because obviously we know that older patients are more likely to die just from in general, so we kind of take that one particular bias out of the equation there. And so also note that the rates are going to be expressed in per 100,000 population per year, because if you're looking at overall lung cancer death rates amongst the whole population, it's a pretty low percentage of the whole group, right? So this is a way we can express these very small numbers as a kind of more manageable sort of thing. So again, 191 per 100,000 population per year. So, and that was the number for the lung cancer death rates in those male smokers versus rate in non-smokers, 8.7 per 100,000 per year. Okay, so we have these kind of baseline numbers. We'll compare these to the UK numbers in just a second here. And again, if you're looking at the lung cancer death rates in the whole population, if you would actually compare these two, you'd end up seeing that the risk is very, very low, less than 1% per year for the whole population. And so it's difficult to see, big differences or really any differences there. They would look essentially the same. So that's why we're doing it by the per 100,000 people per year. So looking at the attributable risk, you can see the US data is here versus the UK data. And so you can compare these two. So you can see, okay, 191 divided by, 100,000 people per year minus this 8.7 divided by 100,000. So again, this is our denominator essentially. You can see that the attributable risk, because it's an absolute difference between the two, is 182.3 per 100,000. So, some people are just going to die of lung cancer regardless, in these male patients. But this is what we're saying is going to be the attributable risk due to the effects of smoking, right? And of course, you'd actually, if you're doing the real statistics on this, you'd end up coming up with this number plus a confidence interval, and you would expect this to be well over 0, because again, 0 is being our point of no difference between these two groups when we're doing absolute differences. Now, looking at the attributable risk in the UK, you would see that you have 166 in those smokers per 100,000 people per year, -7 divided by 100,000 per year. And so you can see that in the UK, there was a smaller attributable risk compared to those in the US. And so, this could just be due to chance alone. If you did the results for the next year, you could maybe see the exact opposite. You'd have to do statistical testing to determine if there's any actual difference between these two or not. But again, you can start to postulate, if this was statistically significant, what's the difference here? Is there some other risk factor that we did not account for that would be considered a confounder? Maybe diet is affecting this. Maybe exposure to different environments could be things. So this is kind of hypothesis generating a lot of cases, but things to think about when you're looking at these differences in risk. And so here you're kind of looking at that same data, more of a graphical representation. So again, you can look at these values here, and you can look at these bar graphs and kind of see the attributable risk due to things like smoking. So this dark bar is going to be smoking. So if you notice here, if you kind of look at this whole bar here, it's trying to draw this as pretty as possible. This would be considered your attributable risk. Like the risk of lung cancer death is this much higher, right? Some people are just going to die regardless, so this is kind of like your baseline for those that are non-smokers. But this would be considered, this whole area would be considered your attributable risk. And if you were to compare these numbers, obviously as we did in the last slide, you see that for UK patients, this would be a smaller attributable risk, right? So again, this is their baseline. And so smoking had a smaller amount of attributable risk in the people in the UK than it did in the US, right? So maybe they're smoking different types of cigarettes, maybe there's some other confounder that was not taken into account when actually comparing these two. And again, the difference could be due to random chance, but you'd have to do the statistical test to actually determine that. So in contrast to absolute risk differences, we're going to now look at relative differences in risk. And so if you hear a risk ratio, that's another name used for this, and both of them, relative risk ratios, both see them being abbreviated as RR. Basically what you're seeing is that this is going to be a ratio of the risk in the exposed group divided by the risk in the unexposed group. Okay, so when you're dividing one by the other, if there was no difference between the exposed group and the unexposed group, the risk of having the disease outcome, the relative risk or the risk ratio would be 1, right? Because the numbers would be the same in both the numerator and the denominator. And so if they're not the same, then you'd find that when you calculate the risk ratio, it's going to give you a way to kind of determine kind of the relative terms, relative from one group to the other, how different the risk is based on whether they're exposed or not exposed. And so we'll look at some examples of that in just a minute to make that more clear. Typically, if the risk is going to be, the risk of the disease is greater in the exposed group, you're going to find that the relative risk is going to be greater than 1. If it's going to be more protective, it's going to be less than 1. So again, looking at how we would calculate this, and if you were to put in from that same 2x2 table we were looking at before, you would see that the risk in the exposed is calculated the exact same as it was in the absolute risk differences calculation. So these numbers have not changed at all, but instead of subtracting, you're just dividing the risk of the exposed divided by the unexposed. And this gives you a relative risk. Again, if there's no difference here, then this would be 1, right? If it's not 1 and you have confidence intervals to back that up that does not encompass 1, then you can say, hey, this is statistically significantly different. Again, I won't belabor this point again, but you can reference this chart to see where we got those numbers from. So going back and looking at our lung cancer death rates in male smokers versus non-smokers, you can use the same information in order to determine the relative risk as we did to develop the attributable risk. Again, you're just dividing instead of subtracting. So essentially what we're seeing that for these male patients in the US, you just take that number 191 per 100,000 people per year divided by your non-smokers, which was 8.7 per 100,000. The 100,000s would cancel out essentially, and so you'd see that you just have 191 divided by 8.7. And so you end up getting a relative risk of 22. That means those male smokers had a risk that was 22 times higher than non-smokers to have lung cancer death. Okay. If you did the same thing with the UK data, you take 166 per 100,000 divided by 7 per 100,000, and they get a relative risk of 23.7. indicating they were almost 24 times as likely to die of lung cancer as were the non-smokers. So in this case, you'd see that the UK information would lead you to believe that the relative risk is a little bit higher for smokers there than you would see with US patients. Again, this could just be due to chance alone, and so you'd have to do statistical testing to find out if those differences were significant or not. So we'll kind of show you the relationship between absolute and relative risk in the next picture here. And the other thing to consider is like who is really at risk when you're looking at this relative risk. Who are the exposed people who may be contributing to this? So when you're looking at something like a really large relative risk, you can find that even if you have a small number of people being exposed, this could actually lead to excess deaths or these cases of disease. So for instance, if you had something like a genetic abnormality, say something that led to death very early on in life, you could see that even though that would have a very high relative risk of say death, it may only apply to a very small number of people, right? So again, they are the ones that are really driving that excess deaths or a case of disease. On the other hand, if you have a very small relative risk, you can find that this can be statistically important when you're looking at a very large number of people. So if you're say looking at, say a high-fat diet led to increased risk of heart disease, if you apply that out to the entire population, that's where you can see a lot of those deaths start to show up at. So again, it's important to consider if the relative risk is high or low, and then who is really going to be those people that are at risk. How many people actually have that exposure to begin with, and so that kind of gives you some way to kind of make some clinical sense of that and kind of apply it back to your patients. So looking at this graph here, again, looking at your attributable risk, absolute risk here. Again, we mentioned that this kind of this bracket here showing your attributable risk. So you're basically just taking the people who are non-smokers, subtracting it out from the risk of your smokers, and what's left over is that attributable risk that smoking has added on to your risk for developing lung cancer death, right? Now, on the other hand, when you're looking at relative risk, you're going to be dividing the total risk in the smokers divided by your non-smokers, which in this case you kind of consider 1. You can see that this bar is 22 times larger than those who are non-smokers. So your relative risk is 22 times more risk for developing lung cancer death than you would see if you were a non-smoker. So something else you've probably heard of in literature is going to be what we call an odds ratio. And so it's important to understand the differences between relative risk and odds ratios and when to use them. Based on what we were saying previously in that table, we saw that the risk of disease in an exposed group, right? Because when we're doing like a prospective cohort study or something like that, you kind of know who your entire cohort is. You know who your population is because you're setting them up. You're the ones you've entered them into the trial. So again, in this case, you'd be looking at A plus B as being your denominator because those are all the people who had the exposure, and then looking at the actual risk of the disease is A, right? Those are the people that develop the actual disease. So that would be your risk in those cases. Now, if you're looking at odds of something occurring, you're basically looking at the odds of disease in the exposed group is just A divided by B. So the odds of someone having the disease versus not having the disease is just A divided by B. If you have a very small A compared to B, the odds end up being very similar to the risk. The number's not exactly the same, but if it's something that has a very low occurrence, they tend to be pretty similar. So for instance, if you're looking at a particular disease that occurs, say, in 1% of the population, so one person among a group of 100 persons in a given year, you would say that, okay, well, the risk is just going to be 1 divided by 100, or say 0.01, right? So 1% risk, versus the odds of that are going to be 1% having the disease versus 99 who didn't. And so you can see here that the odds would be 0.0101. So pretty similar. And that's going to be important that these are pretty similar when the disease rates are pretty low. And this is important because odds ratios are going to be very useful when looking at case control studies and these kind of retrospective sort of studies. So if the risk is relatively large, so say greater than 5%, you're going to find the odds ratios doesn't really hold up very well because, again, that is draining from that denominator, right? So the more people who have the disease, kind of that B variable gets smaller, and so that kind of changes what the actual odds ratio is going to be. So in those cases, it's not going to be super useful. But if it's a relatively low occurrence, something less than 5%, then it's pretty good estimate, right? So it's good enough for government work, so to speak. So what we can do when we're developing odds ratios is basically we can calculate it by dividing the odds of exposure in the disease group by the odds of exposure in the non-disease group. Remember, when we're doing these case control studies, we're looking at people who already have the disease and then matching them with people who do not have the disease. And then you're looking backwards to see what the odds were of those people having an exposure to a vaccine or to a high-fat diet or whatever it happens to be. And so when you calculate that out, you can see that this is going to be the odds of someone being diseased, the disease patient with the risk factor divided by the disease patient without the risk factor, and that whole product is divided by people who did not have the disease with the risk factor divided by people who did not have the disease without the risk factor. We'll look at that table again, and so that kind of makes more sense. Based on these divisions here, you can kind of flip it around, so you'd have the A times D divided by B times C is going to give you your odds ratio. I'm not going to actually have you calculate that out, but just know that this is kind of where these odds ratios are coming from. It's not going to be calculated the same as a risk would be. Okay, and so when you're doing this, you can see that A times D. So again, this is going to be people who have the disease, who have the positive risk factor, and then those without the disease, the negative risk factor, divided by B times C essentially, and that's going to give you what your odds ratio is going to be between those who had the disease and what the odds were of them having that exposure or not. So the reason why we can't really do risk, absolute risk, or relative risk when you're doing a case control study, when you're looking retrospectively, is the fact that we don't know what our entire population is, right? Because when we're doing say a cohort study, we're kind of setting up who our cohorts are, and so we know what our denominator is. But when you're doing these retrospective studies where you're starting with people who have the disease, you're not capturing every single person who has the disease, right? So you can't really know what your denominator is, but you can look at what the odds are, right? The odds of having an exposure based on whether someone has a disease or not. And so what we can do is use odds ratios for these case control studies, and they give you a pretty good estimate of what the risk ratio would be had you done say a more time-consuming, a very costly sort of prospective study. So because of that, it's generally pretty good and good enough in order to at least get some preliminary studies done, and then we'll give you some good ideas if you did the prospective study, kind of what your results might be. And so you'll find that this is done a lot of times for, let's say, student research or kind of initial sort of hypothesis generation. If you look and see this association, then you can say, okay, well, I have this data that kind of supports me doing a prospective study to see if I find the same results or not. So again, odds ratios tend to be pretty good close estimation of the risk ratio if that risk of disease in the population is very low. So again, if the risk ratio is less than 1%, it can be used, and probably if it's less than 5%, but certainly the lower the actual risk of disease, the risk ratio of that disease, the closer it's going to be. So one of the most useful things we can do with this information about odds ratios and relative risk and all of that is to look to see how much disease burden is caused by certain modifiable risk factors. And this is really important for public policy and things like that, because we want to look to see like what are the most cost-effective things, or what are the most cost things that are the cheapest but get the most bang for our buck essentially in modifying these diseases. This is why things like behavioral changes are so important to look at, because we can do things like if you stop smoking, all these additional health benefits, and it's relatively cheap to do versus say like giving someone a lung transplant after they've been smoking for forever. And so health education is oftentimes a lot more effective when educators can really show how big of an impact the given risk factor has on individual risk. And so if you can show that, listen, this risk factor is huge implications for causing all these different diseases, this is why I want funding in order to start a health prevention or health education campaign in order to correct this, right? And so again, we're looking for the most bang for our buck. And what you need in addition to showing things like risk differences, relative risk, and odds ratios are some of these things we're going to look at in just a few minutes. But we're going to be looking at things like attributable risk percent in exposed individuals, population attributable risk, and then this population attributable risk percent. So again, just keep in mind how we measure these different things, or how we're actually calculating them, how we calculate risk difference versus a relative risk versus an odds ratio, right? So again, keep in mind just these relationships between them and how they differ. I'm not going to have you actually calculate out or do any kind of division or multiplication, but at least be able to, you should be at least be able to calculate an absolute risk difference. But I will have you more do of the interpreting on the exam rather than actually doing the calculation. And this is how we calculate those additional components that I was kind of mentioning. Again, we're going to go over this more in detail in just a few slides here. So just kind of keep this in mind. You can reference back to this later on. So looking at the attributable risk percent in the exposed individuals can help you to answer questions like, say, for instance, among smokers, what percentage of the total risk for fatal lung cancer is due to smoking? And so to calculate that, this is where we need this attributable risk percent in the exposed, which gets abbreviated as the AR percent exposed. And so there's two ways we can do this. We can either look at based on absolute differences in risk, or we can do it based on relative differences in risk. All right, so we've seen that essentially the way we can calculate this is looking at the risk of the exposed individuals minus the risk of the unexposed divided by the risk of the exposed, and you would multiply that by 100 in order to get your percentage. And I'll kind of go into more detail on what this really means in a second here. But if we go back to that lung cancer death rates we were talking about from 1986, you can see here that you basically take your risk of people who are smokers, so 191 per 100,000. Minus 8.7 per 100,000, and then divide that by this 191 again, right? So the risk of the exposed is both in the numerator and the denominator. Multiply that by 100, and essentially what you're seeing is that you would get 95.4%. So that's saying that of the people who are smokers that died of lung cancer, what percentage of them was it due to because they were smokers, right? Because we saw that even in non-smokers, some people die from fatal lung cancer regardless, but we're trying to see like what is the actual impact of smoking in those who are smokers, right? So you see that 95.4% of those people who died that was due to the fact that they were smokers, essentially. So if you don't know what the absolute risk is, you can do it with relative risk instead. And so you can do it with this equation here where you do relative risk minus 1, because we know that the relative risk in the unexposed individuals is automatically 1, right? Because they're kind of your baseline. Divide by that relative risk, and then again multiply it by 100. If you then sub in that information, we saw that previously our relative risk was 22. Do 22 minus 1. Divided by 22, multiply that by 100, and you get 95.5%. So pretty close to this 95.4%. Again, close enough for government work. And so what you're saying is that those individuals who are smokers, the percentage of lung cancer deaths associated due to smoking was 95.5% of those. So just to reiterate the point that, again, you can use relative risk in place of absolute risk differences, because we know that basically the relative risk for the unexposed group is always going to be 1, right, because they're your baseline. You can sub in that relative risk for the exposed minus 1, and that's going to go ahead and give you this relatively same number as if you had an absolute risk difference available. And so again, because we mentioned that when the occurrence of disease is relatively low in the population, especially less than 1%, you can sub in the odds ratios as well, and that would again give you a very similar estimate without having to do, say, like a prospective sort of study. So again, if you're doing a case control study, that's where you could use the odds ratios, and that can be very useful. So the next thing we're going to look at is what we call population attributable risk. And so it's basically saying that if you looked at the entire general population, how much of that total risk for something like lung cancer deaths are due to exposure to, say, smoking. Okay, and so you can basically calculate this by looking at the risk of the whole population minus the risk of the unexposed, and what's left over should be the risk of those people who are smokers. Not so useful when you're applying it to, say, individual patients to letting them know what their risks for disease are, things like that, but it can be very useful for things like policy generation. So, for example, if we're looking at the data from 1986 again, we can see that if we subtract the risk of adult male non-smokers, which in this case would be 8.7 out of 100,000, from the risk of the total adult male population, so this would be 72.5 divided by 100,000 per year. And again, this is a value that's provided. You'd be fine, and again, subtracting this out, you'd basically have 63.8 individuals per 100,000 per year. So it's saying that just due to, if you take out all the people who would died of lung cancer regardless of exposure to smoking, or those who are unexposed, I should say, you have this many people left over. This is the additional number of people over that 8.7 who are dying just due to smoking, essentially, or at least that's what you're postulating. And so when looking at that, you can say, well, this is a pretty big number. This is, assuming you had no smokers at all, you should get your number much closer to that 8.7, right? So due to that, it's something that can lead lawmakers and policymakers to think, hey, this is something that's, pretty identifiable as like, yes, this isn't one of the main causes for this. Let's go ahead and see if we can do something about it. Say, do things like health interventions or whatever you have to do. So again, this is more useful to more like kind of the broad kind of general population sense than just individual patients. And then the final value we're going to talk about here is this population attributable risk percent. And this is very, very similar to the attributable risk percent in the exposed. Essentially, you're just subbing in the risk in the exposed individuals for that risk of the total population you're interested in. And again, it's answering a very similar question. It's just saying that among the general population, what percentage of the fatal lung cancer was due to the exposure, or in this case, smoking. And so if you were to look at the risk in the total population minus the risk of the unexposed, right? So now you're kind of left over of people who were exposed, divided by that total risk, and then multiply by 100 to get your percentage. And again, if you were to sub in the numbers from the general population minus the non-smokers divided by the risk of the whole population, you get 88%. So you can say that yes, in the whole population, all these excess deaths are occurring, but 88% of them are due to smoking. Now you could also use relative risks and odds ratios if you're doing like a case control study, for instance, to develop your population attributable risk percent. The only thing you have to sub in though is going to be the proportion of people who are smokers amongst the population. So this is this PE value that gets added in here, and this is basically utilized to help kind of estimate, what's the actual percentage of the population who's actually at risk or being exposed in the first place. And so, for instance, when you did this, their PE was assumed to be about 35%, but obviously we know things like smoking change over time, and so currently it's probably less than 25% adults in the U.S., which is a good thing. So you would be seeing these numbers change as time goes on. So if we were calculating this again using relative risk based on the numbers we saw previously, which was 22 for those adult male smokers, we use that number. You can see that 0.35, which is assuming 35% of that male population was smoking, times 22 minus 1. So again, it's just your relative risk of exposed versus non-exposed minus 1. Again, that's just going to be that risk, relative risk for those who are not exposed, and then divide this out, and essentially what you're going to get is around 88%, which is pretty close to if we just were using absolute risk differences. So again, we'll show you diagrammatically in a second here how you can kind of how that formula works. So looking at this graph, we can kind of figure out how we can use relative risk in order to determine what this percentage is for the whole population. And so essentially what you can see is that this line here is going to be this kind of baseline risk for lung cancer death, regardless of exposure to smoking or not. And so what you want to see is that based on the number of people who are smoking, or this proportion of people who are smoking in the population, which of them died due to fatal lung cancer, or what percentage of those were due to actual smoking. And so now we can factor in our percentage of the population who's exposed, right? So this is at 35%. So this section here is going to be people who are non-exposed, the greater population, who would have died of lung cancer regardless. They were unexposed, but they are going to die. They have a set risk. We also want to get rid of this risk of those who are smokers in the population who were basically going to die regardless of despite the fact that they were smoking, they were going to die of lung cancer anyway. Right, so we want to get rid of that because we want to figure out exactly what percentage of the population, what number of these deaths are due to this exposure to smoking. And so what we're really trying to hone in on is very specifically just this bar here. And so by knowing that population percentage, we can really do that. We can hone in and find out what this bar is, and that tells you out of the whole population using a relative risk, what percentage of those deaths are attributable to the exposure of smoking. So how do we use this risk assessment data? That's what we're going to look at next. All right, so let's show how we can use this population attributable risk information to help us determine the potential benefit of a proposed intervention. So let's say that we want to initiate a new program to help reduce smoking rates in say a large population. And so say we have the U.S. population we're dealing with, we're looking at men who are smoking, and let's say we have a current average of about 25%, say for more than 2 decades. This would be similar to what it was in the 1990s essentially. And then assume that the amount of smoking has been pretty consistent or constant among men who smoke, and that lung cancer death rate in that group remains constant as well, right? So you're kind of having to make some assumptions, but it's useful for helping to estimate what these impacts could be. And so based on that, what we can see is that we can determine lung cancer death rates as based as a total of that adult male population based on the weighted averages of these rates in smokers versus non-smokers. So looking at this value here, or this equation here, we can look at rate per 100,000 male population per year would equal the weight of the smokers, the percentage of the population that are smokers, times the rate of the actual lung cancer deaths plus the weight of the non-smokers plus the rate of their lung cancer deaths. And so what you can see is you assume this 25% the male population are smoking times their rate of death per 100,000 plus 75% of the population who's not smoking times that 8.7, and basically what you get is you add these up, and you should assume you're estimating that per 100,000 male population per year out of the whole population is going to be 54.3. Now what we can do is figure out this population attributable risk and express this as a rate per 100,000, and can calculate as that 54.3 deaths per 100,000 in the whole population minus the non-exposed, and so you end up getting 45.6. So now you're saying that based on this calculation, per 100,000 male patients per year, you're getting 45.6 deaths that are attributed just to smoking alone, right? So let's say we had a program where we want to reduce the proportion of male smokers from 25 to 20% for an extended period of time. And again, assuming these lung cancer death rates were remaining pretty constant, there's nothing else kind of really changing here. We can get a revised rate of lung cancer deaths and calculate that out. So again, going back and changing, basically the only variable we're changing is this weight of the smokers versus non-smokers. Now we're going from 25 to 20, and then going from 75 to 80 here. So now we have a larger proportion of people who are non-smokers. And so you end up getting this rate of 45.2, and now we're going to get a new par that we're going to calculate. This new par will be 45.2 minus 8.7, and you end up getting this par of 36.5 per 100,000 due to smoking alone. So looking at this, you can see this difference in rate from the first par is 45.6 versus 36.5 is equal to 9.1 deaths per 100,000 adult men. That means that you're reducing the number of deaths due to cigarette smoking by 9.1 per 100,000. And so basically, you would kind of round that down to 9 because you can't really have a 0.1% of a death or 0.1 death. But anyway, so basically you're saying that if you would extend that out to say 100 million men, the intervention could be responsible for preventing 9,100 deaths per year. Sounds like a pretty good intervention. If you were to apply that both to men and women, you can kind of double that, assuming they had similar rates of smoking and similar lung cancer death rate, and you could estimate that you'd be saving 18,200 deaths or prevent those many deaths per year. Right, so using these kind of estimates, you can say, okay, well, this is the kind of potential impact we think we're going to have, and that could justify either funding or potential policy or things like that to have these interventions being made. And so you can use this table just as a reference. Again, this is where we're getting all these values from. You can see how we kind of got the previous values if you forget. So one of the other big things that you'll find being done in these epidemiologic studies are cost-effective analyses. We're basically looking to see, like, if we have an intervention, how can we kind of go back to dollars and cents as far as the interventions are going to be achieved, right? Or the effects are going to be achieved here. So you can look at things like injuries, you can look at illnesses or deaths prevented. Those are kind of commonly measured items in a lot of these cost-effective analyses. And these are generally going to be more difficult to measure these effects because a lot of times they take a long time to measure. So, someone who stops smoking now may not benefit from that lung cancer death being prevented for 20, 30, 40 years potentially, right? And so you can kind of equate it back to these potential costs and get a better idea of just how cost effective these interventions are going to be. So for instance, if we had a smoking reduction program and say the cost of the program were $1 billion per year, okay? And we know that based on the assumptions that we can save 18,200 lives or prevent this many deaths per year. So if you were to divide that 1 billion by 18,200, you get roughly $55,000 to prevent each death. Okay. However, if you were to say assign the cost out to all the population, 200 million adults, let's say $5 per adult per year. Okay. Seems like a little bit easier to swallow from that standpoint. Or if you just wanted to attribute those who benefited, those 18,200 who are going to actually benefit from that, that 5%, or the 5% who went from, say, smoking to non-smoking, you could basically you attribute about $100 per quitter per year, right? So that's kind of the cost it would take, about $100 per person who ended up quit smoking that year, essentially. So, but preventing lung cancer death isn't the only benefit here. The smoking reduction would have lots of other benefits as well. You may see reductions in rates of, say, non-fatal illnesses. You may have less COPD, MI, other types of cancers. And so, based on that, these analyses are typically pretty complicated, and they're trying to factor in several of these different factors as far as like the prevention goes of these different disease states or these different causes of death. And so, if you factor all that in, obviously, the cost would go down pretty drastically. So go from $100, per quitter made down to cents potentially. And so, how you define these outcomes of interest can define how cost effective a program would be. And so again, it's all about definitions, all about how they kind of show the numbers and how they kind of equate things back to these interventions. So in order to perform these cost-benefit analyses, you have to be able to convert the positive effects of your intervention into a dollar amount, right? So, what is the actual positive effects of reducing these lung cancer deaths? And so there's several things that go into it, things like savings in medical care, if you're not in the hospital as much, or if you're able to work for longer because you're not in the hospital, you're not super sick. All of that has to get factored into it, right? Because you're a productive member of society for longer, essentially. And so you have to generate these average costs, and then we have a lot of studies and a lot of data that is generated to kind of help inform this. And so you need to have an estimate of the average cost of care for one case of lung cancer, essentially. So you're looking at dollar values in terms of productivity if you were to add on an additional year of life, and then you have to factor in the average number of productive years of life gained by preventing that cancer. So, how much extra value, as far as the dollar value goes for each year, and then how much longer are they living for, essentially. So money is obviously not the only way we can express the benefits of interventions or risk factors. And so, we will find that you need a variety of ways to express this information to make it usable by, patients, physicians, lawmakers, etc. And so we're going to talk about a few of the ways we can do that, utilizing different, so a lot of the concept we've already seen during this lecture. So let's talk about one of these ways that we can describe the impacts of an intervention to patients or to other providers, things like that. We can use absolute and relative risk reductions. And this is similar to what we've already seen previously. But an absolute risk reduction would be something where we actually would subtract the risk of those who are exposed minus those who are unexposed. And that difference there is going to be, what the change is in your risk if you were to become an unexposed individual, essentially. So in this case, we're going to look at an instance where the disease occurrence here in the general population for those who are exposed is 1% versus 0.4% essentially. And so you can see if you were to just subtract this out, you end up getting this 0.006 or 0.6% reduction in the occurrence of disease if you were to become an unexposed individual. That's not super useful of a number, but we can convert that into a relative risk reduction, and this becomes an actual percentage that's going to be a lot easier to utilize. So looking at the reduction in risk of taking your exposed minus your unexposed and then dividing that by those who are exposed, you see the actual reduction in risk that occurs here in about a 60% reduction. So you can say that it does not mean you're going to only have a 40% chance of developing the disease, but it means that you going from being an exposed individual to unexposed by stop eating so much salty food or by stopping smoking or whatever, you end up having a 60% reduction in your chances of developing that disease. Right, so that means you're becoming closer to those who are unexposed. You're having a pretty decent reduction. And hearing a 60% reduction sounds a lot better. It's easier to swallow from that standpoint for like a patient or a healthcare provider. And so you can see things like relative risk reduction being applied to things like vaccines, because typically this has like a protective sort of efficacy. You can see how effective it's going to be based on that kind of risk reduction to developing whatever the disease is going to be, pertussis, HPV, whatever it happens to be. Another really good number to kind of wrap your head around is going to be number needed to treat and number needed to harm. This is very nice ways in order to express how many patients you need to treat in order to cause an event to occur, essentially. Or not occur as the case may be. So what we can use is, and this is where our absolute risk reduction is going to come back into play here, but we can have this n-tiered number needed to treat. And basically this means that the number of patients you'd have to treat with the specific intervention in order to, for one person to benefit from it. And so essentially what we can do, and obviously the number needed to treat, the smaller the number is, the better off we're going to be, right? Because it means you have to treat a smaller number of people in order for one person to benefit. So a number needed to treat, say 100, is going to be worse than if you only had an NT of say 10. But basically how we calculate this is going to be by using the number 1 divided by the absolute risk reduction, right? It's not the relative risk reduction, but the absolute risk reduction. Do 1 divided by that ARR, or in that case we were looking at previously, 1 divided by that 0.006, and this is going to give us the number needed to treat. So an example of number needed to treat would be, say we had this hyperbaric oxygen therapy that was used to heal leg ulcers, and a third of patients who had ulcers that were resistant to all their forms of treatment, right? So they failed everything else, and this is kind of what they're going to. And so in this case, they would end up having an absolute risk reduction of 0.333 repeating. And so if you take 1 divided by that absolute risk reduction, you end up getting 3. This means that I would need to treat 3 patients with leg ulcers in order to have 1 patient benefit. And so this is very useful because you can compare it now to other types of therapies. You may have a number needed to treat of, say, 10. And so obviously a number needed to treat of 3 is going to be better because I have to treat fewer patients for 1 to benefit than this other therapy that may require 10 patients be treated for 1 to benefit. Okay, so that's important to consider, is that lower numbers are better for a number needed to treat. You also have number needed to harm, and basically this could be applied to the negative effects of a treatment. So the number of people you'd have to treat in order for them to experience a negative outcome, whatever you've kind of defined. And so here you want number needed to harm to be higher. So you want to have a very large number for number needed to harm and a very small number for number needed to treat. Here you're going to see that the item we're going to use is not absolute risk reduction, but absolute risk increase. And it's very analogous to the absolute risk reduction. It's just in regards to the increased risk of a negative effect occurring here. And it's going to be calculated the same as number needed to treat. You just have 1 divided by the absolute risk increase, and that again would give you a number needed to harm. So an example of this would be a trial where basically they had infants who were given iron fortified formula and those who were given formula without iron. So basically just kind of regular formula. And so the basically the moms were asked to report whether the infants had symptoms of colic based on which type of formula they had. And so what they saw, they had a reported occurrence of colic in 56.8% of kids getting the iron fortified formula and only 40.8% of infants receiving the regular formula. So now having that percentages, we can calculate a absolute risk increase, which in this case would be 0.568 minus 0.408, and you end up getting this 0.16. So that's our ARI in that case. So if you were to take 1 divided by that 0.16, you end up getting 6.25. Basically, that was suggested by giving infants iron fortified formula. For every 6 to 7 of those that you were giving that formula to, one of them would develop the instance of colic, essentially. Now keep in mind, some of those kids are going to have colic regardless, so this is not going to be the only factor here, but when you're considering whether or not you're giving iron fortified formula or not, you can see just what that number needed to harm is just based off due to the impact of the formula itself. So kind of tying it all back together and seeing how we can apply these concepts back to actually counseling your patient. Here's how we can use several of these different concepts in order to apply to your patient to let them know just how dangerous something that they're doing is, or the reason why they should quit a certain sort of behavior. But let's look at this smoking data. We can see here that smokers are about 22 times as likely as non-smokers to die of lung cancer. That can be a pretty powerful kind of motivator when imagine talking to your patients. You're 22 times as likely to die of lung cancer because you smoke, right? About 95 out of every 100 lung cancer deaths in people who smoke can be attributed to the fact alone that they smoke. Okay. Also, good information for patients to have. These are all different ways to say very similar things, essentially. There are about 158,000 deaths from respiratory tract cancer in the U.S., and 88% of that can be attributed just to smoking, which means that smoking is responsible for about 139,000 respiratory tract cancer deaths per year. And then assuming you can kind of go back to looking at the actual number needed to harm approach, if you're to look at the attributable risk to that being 0.00191, this would mean that if you take 1 divided by that 0.00191, you get about 524, which means that for every 524 adult, every 525 adult smokers per year, one of them is going to die of fatal lung cancer. So again, different ways to convey very similar information to say, hey, don't smoke, it's pretty bad for you. For some patients, this can be a powerful motivator. Some people are going to scoff at the numbers, they don't really care so much, but it's important you kind of cater your approach based on the type of patient you're dealing with. So that wraps up for this section. If you have any questions, let me know. Otherwise, I'll see you for the next one.